Welcome, curious minds, to another deep dive. Have you ever found yourself needing a fast track to truly grasp a complex topic, to get those uh, aha moments without feeling completely swamped by information?
Yeah, that feeling of just drowning in data.
Exactly. That's exactly why we're here. Today, we're plunging into a vast and incredibly important field, mental health. We've gathered, well, quite a stack of sources packed with crucial insights and practical knowledge.
Mm-hmm.
Our mission: to extract the most vital nuggets for you, shining a light on the points that are absolutely essential to truly understand this intricate landscape. The things Dr. Harp really emphasized, we need to nail down.
Indeed. Mental health touches every single aspect of our lives, and the sheer volume of information out there can often feel overwhelming. It really can.
Totally.
So our goal in this deep dive is to synthesize key concepts, ranging from understanding specific disorders like schizophrenia to the critical nuances of how patient care actually unfolds. We want to ensure you walk away not just informed, but truly well-equipped to think critically and, importantly, compassionately about these topics. We'll be focusing on that foundational knowledge, those real must-knows that provide a solid framework for understanding.
Perfect. So if you're ready to gain a clear, concise, yet surprisingly detailed understanding of some core mental health concepts and care strategies, let's unpack this material together and see what fascinating and often surprising insights await. Let's begin our deep dive with a condition that affects millions globally and can profoundly impact a person's reality:
Hmm.
schizophrenia. What exactly is it, and what are its defining characteristics?
Okay, so schizophrenia is a serious mental health condition. It impacts about 1% of the global population.
1%. That sounds small, but worldwide.
Exactly. It translates to roughly 81 million people. That's a lot of lives affected. It typically emerges in early adulthood, most commonly between the ages of 15 and 25.
So quite young.
Very young, often. And while individuals experience periods where symptoms might get worse, then maybe lessen a bit exacerbation and remission, its core characteristic, its real hallmark, is psychosis.
Psychosis. Okay, and what does that mean exactly?
It means a significant, often really frightening loss of contact with reality. This primarily shows up as hallucinations, seeing or hearing things that aren't there, and delusions, which are false, fixed beliefs.
That sounds incredibly disorienting. What are the underlying factors? What contributes to someone developing schizophrenia? Are there specific risk factors or maybe other conditions that often go hand in hand with it?
Yeah, it's definitely a complex interplay. Our sources confirm that genetics play a huge role, a really huge role,
How huge?
accounting for about 80% of the risk. But it's not purely genetic. That predisposition often interacts with environmental stressors, things like significant trauma, chronic stress, maybe even exposure to certain viruses early in life.
Ah, so nature and nurture, essentially.
Yeah, precisely. And when we look at brain chemistry, dopamine, serotonin, and glutamate are key players. Dr. Harp actually gave us a mnemonic for this one.
Oh, yeah.
DGS, don't get schizo.
Okay, DGS, dopamine, glutamate, serotonin. Got it.
Exactly. These are critical neurotransmitters, and their dysregulation is strongly linked to schizophrenia. We also see actual structural abnormalities in the brain itself.
Okay. And what about those other conditions, the comorbidities?
Right, that's really important too. Substance use is incredibly common.
Like what kind of substances?
Well, nicotine use is very high, but also illicit drugs. And this can really complicate treatment and worsen symptoms, as you can imagine.
Mm-hmm.
There are also high rates of anxiety and depression, and tragically, a very, very high risk of suicide among this population.
That's devastating.
It is. And there's another less commonly known physical issue called polydipsia.
Polydipsia.
Yeah, it's excessive thirst, which might sound minor, but it can lead to dangerously low sodium levels in the blood, hyponatremia. And that can actually progress to coma, even death, if it's not managed carefully.
Wow. I had no idea.
It's also a stark reality that individuals with schizophrenia often have a significantly shorter lifespan, by about 20 years.
20 years. Why?
It's a combination of factors, these medical comorbidities we mentioned, lifestyle factors, challenges with accessing consistent health care. It all adds up.
That's a lot to take in. So if we understand what schizophrenia is, how does this illness typically unfold over time? I know Dr. Harp really emphasized the importance of understanding its distinct phases for effective care. Can you walk us through those stages?
Absolutely. And you're right, this framework is vital. Dr. Harp stressed this. It helps us understand the illness's trajectory and tailor care because each phase presents different challenges and different goals.
Makes sense.
Okay, first we have the prodromal phase. This is the earliest stage. It's marked by subtle, often kind of non-specific changes.
Like,
You might see shifts in mood, maybe the development of some obsessions, or just a gradual decline in overall function, school, work, social life. It can be quite long, lasting anywhere from 1 to 12 months before the first acute psychotic break.
so it can be easy to miss initially.
Very easy. Recognizing these early, often quiet signs is incredibly important for early intervention, though.
Okay, phase 1, prodromal. What's next?
Next is the acute phase. This is typically when the illness becomes undeniable and the symptoms are most intense. Those positive symptoms, like vivid hallucinations and really firm delusions, are at their peak.
We'll get into what positive means in a sec, I know.
Right. During this acute phase, judgment is significantly impaired. There's often a heightened risk to the individual's safety, or maybe the safety of others. So the primary goals here are paramount: ensuring safety and achieving psychiatric stabilization.
How do you do that?
It involves reducing overwhelming environmental stimuli, keeping things calm, and diligently working to build trust. Communication needs to be really simple, concrete, and direct. No ambiguity.
Got it. Acute phase, stabilization and safety.
Then we move into the stabilization phase. Here, the intensity of symptoms begins to reduce as treatment starts working, and the initial steps towards functional recovery begin. The focus shifts quite a bit here.
Towards what?
Towards ensuring medication adherence, which is just vital for sustained improvement. Education becomes crucial about the illness, symptoms, the treatment plan for the patient and their family. Therapy, both individual and group, and team-based care involving different professionals are all emphasized.
So recovery is starting. Focus on adherence and support.
Exactly. And finally, we reach the maintenance phase. This is often described as establishing a new baseline for the individual.
A new normal?
Kind of. While positive symptoms might be well managed by now, it's important to realize that cognitive and negative symptoms can often persist, and these can really impact daily life.
Right, the ones that take things away, essentially.
We'll define those, yes. The long-term aim in this maintenance phase is promoting the greatest possible independence and continued recovery. So, consistent medication adherence, ongoing education about managing the illness long-term, and continued social skill building are key, helping the person reintegrate and find a fulfilling life.
Okay, that phase model, prodromal, acute, stabilization, maintenance, seems crucial. Thanks for walking through that. Now, as we unpack these phases, Dr. Harp really wanted us to know the 4 core symptom categories inside and out, especially those terms positive and negative symptoms, which can be confusing. Let's really break them down.
You're absolutely right. The terms are counterintuitive. They don't mean good or bad. Getting this distinction is critical, like Dr. Harp stressed.
Okay, lay it on us. Positive symptoms first.
Right, positive symptoms. Think of these as behaviors or experiences that are added to the person's normal functioning things that shouldn't be there. An addition of something abnormal.
Added symptoms, like what I thought.
Okay, first, hallucinations. These are sensory experiences without any actual external stimulus. Seeing, hearing, smelling, tasting, feeling something that isn't there.
Hearing voices is the most common.
Right, far. Auditory hallucinations are the most common. These voices might comment on their actions, argue, or even give commands. We'll come back to command hallucinations specifically.
Okay, hallucinations. What else?
Delusions. These are false, fixed beliefs. They're firmly held despite clear evidence against them, and they aren't part of the person's cultural background.
Examples?
Believing you're a famous historical figure or convinced you're being persecuted by a secret organization, maybe that aliens are controlling your thoughts, things like that.
Got it. Fixed, false beliefs. Anything else in positive symptoms?
Yes, disorganized speech. This shows up as severe disruptions in thought processes, making speech hard to follow, like word salad.
Word salad?
Yeah, it's like a random jumble of unconnected words. Grammatically, the words might be okay, but strung together, they're meaningless, like, tomorrow the purple happy runs car.
Whoa.
There might also be neologisms, which are basically made-up words that only have meaning to the person speaking them, or clang associations, where they string words together based on rhyme rather than meaning.
Fascinating and difficult. Any other positive symptoms?
One more category, behavior changes. This refers to grossly disorganized or abnormal motor behavior. like catatonia, which can range from complete immobility, like being frozen, to repetitive, purposeless movements, or echopraxia, which is mimicking the movements of others. Also, boundary impairment, difficulty recognizing personal space.
Okay, so positive symptoms are added things.
Mhm.
Hallucinations, delusions, disorganized speech, and behavior changes. Now, negative symptoms.
Right. Negative symptoms, these are things missing from normal behavior or function. They reflect a deficit or absence of typical mental processes, and these can often be more debilitating long term.
Missing. Okay, like what?
Well, there's anhedonia, the inability to experience pleasure from things that are normally enjoyable hobbies, social interactions, food.
That sounds awful.
It is. Then avolition. A severe lack of motivation, the inability to start or persist in goal-directed activities, like work or school.
Lack of drive.
Exactly. A sociality, which is a significant lack of desire for social interaction. Not just shy, but really withdrawn. Alogia, also called poverty of speech, a big reduction in speech quantity, or giving very brief, empty answers.
So, less talking.
Right. Affective blunting, which is a reduced or flattened range of emotional expression, like very little facial expression, monotone voice, and often poor hygiene due to that lack of motivation, the avolition.
Okay, so negative symptoms are deficits. Anhedonia, avolition, asociality, alogy, affective blunting, poor hygiene. What's the third category?
Third, cognitive symptoms. These involve difficulties with fundamental thought processes and what we call executive functions, planning, organizing, decision-making.
Like memory problems.
Yes, impaired memory, especially working memory. Also impaired attention, difficulty sustaining focus, and impaired judgment, making poor decisions. Another key one is concrete thinking, the inability to think abstractly, taking everything literally.
And didn't Dr. Hars really emphasize one cognitive symptom in particular?
Yes, absolutely. Anosognosia. This one is critical to understand. It's a lack of awareness or denial of one's own illness.
Isn't that just denial, like a coping mechanism?
No, and that's the key point Dr. Harp stressed. It's not just psychological denial. It's considered a neurological impairment, part of the illness itself. Individuals genuinely don't believe they're ill, even when faced with clear evidence.
Wow. So they truly don't see it.
Correct. And you can imagine how this makes treatment adherence incredibly challenging. If you don't think you're sick, why take medication or go to therapy?
Yeah, that's a huge barrier. Okay, cognitive symptoms. And the fourth category.
Fourth, affective symptoms. These relate specifically to mood and emotion.
Like depression.
Exactly. Mood instability and depression are very common. Individuals often experience significant swings in mood, intense sadness, irritability. And this category carries that high risk of suicide we mentioned earlier. These affective symptoms are often described by patients and families as the most debilitating group because of their profound impact on daily life and overall risk.
Okay, those four categories, positive, negative, cognitive, affective, give a much clearer picture. Let's maybe zero in on a few of those specific symptoms you mentioned. Word salad, can you give another example maybe? It's hard to picture.
Sure. Word salad or schizophasia is really at the extreme end of disorganized speech. The words themselves are real, grammatically okay maybe, but the sequence is just completely illogical. Like hearing someone say, "Blue walked dogs happily under the fast lamp."
Right, makes absolutely no sense. It's not just jumping topics, it's incoherent words.
Exactly. It lacks any discernible connection or internal logic, even a distorted one. It's different from, say, loose associations where the ideas are loosely connected, but there's some connection. Word salad is just a jumble.
Got it. And then command hallucinations. You said we'd come back to those. They sound particularly dangerous.
They are, and Dr. Harp highlighted these as absolutely essential to assess for because of the risk involved. Command hallucinations are auditory hallucinations, voices that specifically instruct the person to perform certain actions.
Actions like?
Well, they can be benign, like go get a drink of water, but critically, they can also be dangerous or self-destructive. Commands like harm yourself, jump out the window, or attack that person.
And people might act on them.
Yes, that's the significant concern. Individuals often feel compelled, sometimes unable to resist acting on these commands. This poses a very real and immediate safety risk, both to the individual and potentially to others. They require immediate assessment and intervention.
Definitely something to watch for. And anosognosia, again, that lack of insight. You said it's neurological, not just denial.
Correct. Dr. Harp truly emphasized this as fundamentally important. Anosognosia is a neurological or cognitive impairment where the person genuinely doesn't believe they're ill or have a deficit, even with clear evidence. They lack awareness of their own condition.
And it's not just in schizophrenia.
No, it's common in conditions affecting brain function. We see it frequently in schizophrenia, but also in Alzheimer's disease, after strokes, sometimes with bipolar disorder during manic episodes.
And the main impact is treatment adherence.
That's the huge practical implication, yes. If you fundamentally don't believe you have an illness, you're unlikely to engage with treatment voluntarily. Why take medication for a problem you don't think you have? It's a major barrier and requires specific strategies to manage.
Okay, so given all these complex symptoms and potential risks, what's the immediate starting point for care? Dr. Harp's insights really stress the importance of a detailed assessment, right?
Absolutely. A thorough, detailed assessment is the foundation for everything else. The initial focus is comprehensive. We start with a meticulous evaluation of the patient's current mental status, looking at everything from appearance, behavior, mood, affect, to their thought processes and content.
The mental status exam.
Exactly. Simultaneously, a rigorous assessment for suicide risk is paramount, given the high rates. And screening for substance use, because that can muddy the waters significantly.
Right. What else is key initially?
A crucial component is reality testing. We need to gauge the patient's ability to differentiate what's real from what's not. Can they recognize hallucinations as not real, or do they fully believe their delusions? Understanding their level of insight is vital.
And checking for those command hallucinations.
Definitely. Vigilantly monitoring for any presence of command hallucinations is critical due to the safety risk. We also need to assess the patient's family knowledge and their existing support systems. Are there people who can help? These are vital resources.
So based on all that, what kind of initial problems or diagnoses might a nurse identify?
Common nursing diagnoses that often emerge initially include things like risk for suicide, risk for other directed violence, impaired verbal communication, risk for loneliness due to that social withdrawal, and feelings of powerlessness. These initial diagnoses then guide the very first steps in planning care.
Okay, so building on that initial assessment, let's now turn to how care progresses, especially the hands-on nursing interventions and the vital role of medication in managing schizophrenia. What happens once someone is, say, admitted and starting treatment?
Right. Once a patient is relatively stable and we have that comprehensive assessment, the nursing process focuses intently on promoting their recovery and managing those persistent symptoms effectively in their daily lives, or within the hospital setting initially.
How do you manage something like hallucinations therapeutically?
It's a delicate but firm approach. We use simple, clear language. Instead of asking, "Are you hearing voices?" which might inadvertently validate the experience as shared reality.
Right, you don't want to confirm it for them.
Exactly. We might ask, "What are you hearing right now?" Or, "Can you tell me what the voices are saying?" This acknowledges their perception without confirming its objective reality. Then we promote reality testing by gently stating something like, "I don't hear that voice myself, but I understand it's real and probably upsetting to you."
So validating their experience while reinforcing reality.
Precisely. We also aim to reduce environmental stimuli. Too much noise or activity can make hallucinations worse. And we encourage distraction techniques, listening to music, focusing on a task, engaging in conversation with staff.
Okay, what about managing delusions? Is it similar?
The strategy is different for delusions. The absolute key here is never argue with or directly challenge the delusion.
Why not? Seems like you'd want to correct them.
Because it almost never works, and it often escalates agitation or breaks the trust you're trying to build. They believe it firmly. Arguing just makes them dig in their heels or see you as part of the problem.
Okay, so no arguing. What do?
Instead, we try to focus on the underlying feelings the delusion might be generating. Are they feeling scared, suspicious, confused? We can validate those feelings. It sounds like you feel very frightened right now.
Focus on the emotion, not the content.
Yes. And we gently reorient by stating things like, "I understand that's what you believe, but from my perspective, I see the situation differently." Then, encourage engagement in reality-based activities, playing cards, talking about the weather, simple tasks to shift their focus away from the delusional thoughts without that direct confrontation.
Got it. And enhancing communication must be important, especially with disorganized speech.
Vital. We use concrete language, short, clear sentences. Avoid abstract ideas or complex instructions. And it's crucial to allow ample time for responses. Processing can be very slow.
Patience is key.
Absolutely. We validate their efforts to communicate, even if it's difficult to understand, and we can sometimes assist with thought organization, maybe through structured conversation or encouraging journaling if they're able.
Safety is obviously a huge ongoing concern, too.
An ongoing priority, yes. vigilantly monitoring for any signs of suicidal or homicidal ideation. And as we keep saying, because it's so critical, specifically assessing for command hallucinations. Maintaining a low stimulation environment is essential if the patient becomes agitated. And clear boundaries and consistent routines are vital. Predictability can be very reassuring and reduce anxiety.
What about basic self-care activities of daily living, or ADLs?
ADLs, things like bathing, dressing, eating, are often significantly impacted by negative symptoms like avolition or cognitive difficulties. Our role is to support them in regaining independence here, offering step-by-step instructions, using visual cues or modeling the task if needed, and crucially, always praising any attempts to complete tasks, no matter how small. Positive reinforcement is really powerful here. Great job putting on your shirt today.
Okay, so lots of practical supportive nursing strategies. Now, medications. Clearly a cornerstone. Can you give us an overview of the types of antipsychotics? And then let's really dive into those side effects that Dr. Harp flagged as essential knowledge.
Absolutely. Antipsychotics are the primary pharmacological treatment, and they've evolved. We categorize them broadly into generations.
Okay.
First, we have first-generation antipsychotics, FGAs. These are sometimes called typical antipsychotics. Think Haldol, Thorazine. They work mainly by blocking dopamine receptors.
You're good for...
They're generally quite effective at reducing positive symptoms, hallucinations, delusions, but they come with a higher risk of significant motor side effects, which we'll detail.
Okay, FGAs. What's next?
Second-generation antipsychotics, SGAs, or atypical antipsychotics. Examples are risperidone, olanzapine, quetiapine, ziprasidone. These block both dopamine and serotonin receptors.
Dual action. What's the benefit?
This dual action helps them target both positive and negative symptoms, which is a big advantage. And generally, they have a lower risk of some of those severe motor side effects compared to the FGAs, though they have their own set of concerns, especially metabolic ones.
Okay, SGAs. Is there a third generation?
Yes, more recently we have third-generation antipsychotics, which are technically a subset of SGAs, but act a bit differently. Abilify, or Piprazole, is the main one. These are often called dopamine stabilizers or partial agonists.
Stabilizers.
Yeah, they sort of modulate dopamine activity rather than just blocking it. They often have an even lower risk of motor side effects, and sometimes might even help with cognitive symptoms.
Okay, FGA, SGA, TGA. Now, the side effects. Dr. Harp really hammered these home. What are the must-knows?
Right. Let's focus on the critical ones Dr. Harp emphasized, because they can be serious and really impact patient well-being and whether they stick with treatment.
Let's hear them.
Okay, the first major group, especially prominent with FGAs but possible with SGAs too, is extrapyramidal symptoms, EPS. These are motor disturbances caused by that dopamine blockade.
Motor problems like what?
There are several types. One, acute dystonia. This is a sudden, often painful, sustained muscle contraction. It can be scary, like the neck twisting, torticollis, or eyes rolling upwards, oculogeric crisis. Usually happens early in treatment.
Painful and sudden. Okay.
2, akathisia. This is a horrible feeling of inner restlessness, an inability to sit still, a powerful, irresistible urge to move constantly. Patients might pace, shift their weight, tap their feet. It's often mistaken for anxiety, but it's a physical side effect.
Inner restlessness. Must be awful.
3, pseudoparkinsonism. These are drug-induced symptoms that mimic Parkinson's disease. Things like muscle stiffness or rigidity, slow movement, bradykinesia, tremors, especially pill-rolling tremor, and a mask-like facial expression.
So looking like they have Parkinson's, but it's from the drug.
Exactly. And 4, tardive dyskinesia, TD. This one is particularly concerning. It's a late-onset syndrome, meaning it can appear after months or years of treatment. It involves involuntary, often repetitive movements, especially affecting the mouth, tongue, and face, lip smacking, grimacing, tongue protrusion. It can also affect limbs and trunk.
And Dr. Harp stressed something about TD.
Yes, that prevention is absolutely key, because TD is often irreversible even if you stop the medication. This is a major reason why SGAs are often preferred now, as they generally have a lower risk of TD.
Irreversible.
Oh, wow. Are there treatments for the other EPS?
Yes, for acute dystonia, akathisia, and pseudoparkinsonism, there are treatments. Dr. Harp specifically mentioned medications like benstropine, cogentin, diphenhydramine, Benadryl, and sometimes amantadine. These can help manage those motor symptoms.
Okay, so EPS is a big one. What else is critical?
Beyond EPS, there are other very serious potential side effects. Anticholinergic toxicity. This is a medical emergency. Too much anticholinergic effect causes symptoms like high fever, very dry skin and mouth, dilated pupils, confusion, delirium, even seizures. need immediate intervention.
Emergency.
Neuroleptic malignant syndrome, NMS. This is another potentially fatal medical emergency. Dr. Harp flagged NMS as absolutely essential knowledge.
What are the signs of NMS?
It's characterized by severe muscle rigidity like lead pipe rigidity, a very high fever, hyperthermia, altered consciousness, confusion, stupor, coma, and autonomic instability. Unstable blood pressure, pulse, breathing. Requires immediate cessation of the antipsychotic and intensive supportive care.
Okay, NMS, another emergency. What else? Metabolic syndrome. This is a huge issue, especially with many SGAs. Dr. Harp highlighted this as essential due to its major long-term health impact.
Metabolic syndrome.
Oh.
That's like weight gain.
Yes, significant weight gain is common, but it also includes new-onset type 2 diabetes, high cholesterol, high triglycerides, and increased risk of cardiovascular disease. Requires regular monitoring of weight, blood sugar, and lipids.
Long-term health risks there. Anything else medication-wise?
Yes, one specific medication Dr. Harp underscored, clozapine, clozaril.
What's special about clozapine?
It's actually incredibly effective, often considered the gold standard for treatment-resistant schizophrenia cases where other meds haven't worked. However, Dr. Harp really emphasized its very high-risk side effect profile. It's typically not a first-line choice precisely because of these risks.
What are the big risks with clozapine?
The most serious is agranulocytosis. This is a severe, potentially fatal drop in white blood cells, neutrophils, which drastically increases the risk of serious infections.
Wow. How is that managed?
It requires rigorous, regular blood monitoring weekly at first, then maybe bi-weekly or monthly if stable through a strict registry system. If the white count drops too low, the medication has to be stopped immediately. Dr. Harp specifically reminded us about this infection risk.
Okay, high infection risk. Anything else?
Yes, there's also a caution regarding seizures, as clozapine can lower the seizure threshold more than some other antipsychotics. So Dr. Harp flagged the infection risk, its typical last resort status, and the seizure caution as key takeaways for clozapine.
Okay, that's a lot of potential side effects to manage. Given all that, how do nurses support patients with medication adherence? It must be incredibly challenging.
It is a huge challenge, absolutely. Compounded by anosognosia and these potential side effects, nurses play a crucial role here. Education is paramount.
Educating about.
Explaining the medication's purpose, why they're taking it, what it's expected to do, and having a really clear, honest discussion about potential side effects, both common and serious, what to watch for, when to report things.
So managing expectations.
Yes, and encouraging open discussion about their concerns. Are they worried about weight gain, sedation, the motor effects? We need to address those concerns directly and collaboratively problem solve.
Involving family helps too, I bet.
Oh, definitely. Involving family and caregivers with the patient's consent is vital for adherence support. They can help with reminders, observe for side effects, provide encouragement, and of course, vigilant monitoring by the healthcare team for severe side effects like EPS or NMS is always ongoing. Early detection and intervention are key.
Makes sense. You mentioned reality testing earlier as a critical nursing intervention, and Dr. Harp included it in the high-yield reminders. Can you elaborate a bit more on how nurses do that effectively without invalidating the patient's lived experience? It sounds like a real tightrope walk.
It is a truly delicate balance, absolutely, but it's central to therapeutic communication when someone is experiencing psychosis. The key, as we touched on, is to acknowledge the patient's subjective experience, what they are genuinely hearing, seeing, or believing, without confirming or validating that experience as objectively real for everyone.
So how does that sound in practice?
Okay, so instead of saying, that's not real, or there are no voices, which is invalidating and likely to shut down communication,
Right.
a nurse might say, I understand that you are hearing voices right now, and that must be frightening, validating the experience and feeling, but I want you to know that I don't hear them stating objective reality gently. Or for a delusion, I understand that you believe the FBI is watching you acknowledging belief, but I haven't seen any evidence of that offering a different perspective.
Ah, okay. It's subtle but clear.
Exactly. This approach does several things. It validates their internal reality, which builds trust. It avoids confrontation that could escalate distress, and it gently grounds them in shared objective reality. It's about promoting insight, encouraging them, even subtly, to question the objective reality of their symptoms, which is a core goal, especially during the acute and stabilization phases. It's a step towards recovery and better management. #, exploring somatic symptom and consciously controlled disorders.
Okay, shifting gears now. Let's talk about something that can be incredibly perplexing for both patients and healthcare providers. Somatization. What exactly is that?
Somatization is a fascinating and often misunderstood phenomenon. It's essentially the expression of psychological stress through physical symptoms.
So mind-body connection stuff.
Very much so. It's like the body's unconscious way of reacting to emotional distress, anxiety, depression, trauma. What's unique is that often these physical symptoms, things like chronic pain, fatigue, dizziness, stomach upset, appear instead of or alongside more typical expressions of emotional distress.
So they might not feel anxious, but they have unexplained pain.
Exactly. Or the physical symptom becomes the main focus of their distress. It's not a conscious choice. It's influenced by a complex interplay of biological factors, cognitive styles, like focusing heavily on bodily sensations, psychological factors like past trauma, and social or cultural factors. And importantly, the specific types of symptoms can indeed vary significantly across cultures. What's seen as a typical physical manifestation of stress in one culture might be different elsewhere.
Interesting. So what are the primary types of somatic symptom disorders, where the symptoms are genuinely experienced, not faked?
Right, that's the key distinction. In these primary disorders, the patient truly experiences the physical symptoms and the distress they cause, and they aren't consciously creating them. There are three main ones.
Okay, what's first?
First, somatic symptom disorder, SSD itself. Here, individuals experience one or more distressing physical symptoms, could be pain, fatigue, shortness of breath, often without clear, sufficient medical findings to explain them.
And they're really suffering.
Genuinely suffering, yes.
Yeah.
They are deeply preoccupied with their symptoms, have excessive thoughts, feelings, or behaviors related to them, and often engage in doctor shopping, going from doctor to doctor, or repeatedly visit the same provider, desperately seeking a medical explanation.
What's the key feature here?
A key characteristic is that they typically don't connect their psychological stress to their physical symptoms. They truly believe their problem is purely physical, and their level of worry and concern is disproportionate to the medical findings. And importantly, patients with SSD are at a significant risk for suicide due to their distress and feelings of hopelessness.
How do nurses approach SSD?
It requires a lot of trust building. Providing consistent reassurance, educating them about the disorder gently, and encouraging self-compassion are key. And absolutely avoiding dismissive or disparaging comments like, it's all in your head. That destroys trust immediately.
Okay, SSD, what's the second type?
Second, illness anxiety disorder. This was formerly known as hypochondriasis.
Ah, okay. I've heard of that.
Right. This involves an extreme preoccupation and worry about having or acquiring a serious illness. This worry persists for at least 6 months, even if somatic symptoms are absent or very mild.
So they're not necessarily feeling symptoms, but terrified they will get sick.
Exactly. Or they might misinterpret normal bodily sensations as signs of severe illness. They're constantly scanning their body for signs of disease. They can be care-seeking, frequent doctor visits, tests, or paradoxically, care avoidant, avoiding doctors entirely due to intense fear of what might be found. Loneliness is often a significant factor here, so addressing social interaction can be important.
Okay, illness anxiety disorder. And the third.
Third, conversion disorder, also called functional neurological symptom disorder. This is characterized by neurological symptoms, things like paralysis, blindness, seizures, numbness, or gait disorders, for which no underlying neurological cause can be found after thorough medical evaluation.
Neurological symptoms with no neurological cause. How does that happen?
It's believed to be related to psychological conflict or stress converting into a physical symptom. It can happen very suddenly, often after a significant stressor. A unique feature sometimes seen is la belle indifférence, or beautiful indifference. It's where patients show a surprising lack of concern or a flat affect about their often quite severe symptoms, like someone suddenly unable to walk who seems oddly calm about it.
Strange. How is conversion disorder approached?
Nursing care avoids directly confronting the presumed stress symptom link, as that's often ineffective. Instead, the focus is on exploring coping mechanisms, building trust, and addressing psychosocial factors like stress or loneliness. Physical therapy might be involved to help regain function.
Okay, so those are the primary somatic disorders. Now, you mentioned a clear distinction for conditions that are under conscious control, where symptoms are fabricated. What are those?
Yes, these are very different because there is deliberate fabrication or exaggeration of symptoms involved. It's conscious deception.
Okay, what's the first one?
First, we have factitious disorder. This was formerly known as Munchausen syndrome.
Ah, Munchausen. Heard that too.
Right. This involves an individual deliberately fabricating physical or psychological symptoms, or actually self-inflicting injury or illness, with the primary motivation being to assume the sick role.
Why would someone do that?
The core motivation is psychological, to gain attention, sympathy, nurturing, or to be cared for within the healthcare system. It's a profound deception where they actively conceal the true nature of their actions. It can be factitious disorder imposed on self
Or imposed on someone else.
Exactly. Factitious disorder imposed on another, previously known as Munchausen by proxy. This is where someone, often a caregiver, harms or induces illness in another person, frequently a child, to gain secondary benefits themselves, attention, praise for being a devoted caregiver, interaction with medical staff. The Gypsy Rose case is a very public example of this.
That's incredibly disturbing. What are the nursing considerations there?
They are critical. The absolute priority is protecting the victim. This involves ensuring supervised visits if necessary, meticulous documentation of observations versus reported symptoms, and being acutely mindful of potential means of harm the perpetrator might be using. Collaboration with Child Protective Services or law enforcement is often essential.
Okay, factitious disorder. What's the other consciously controlled one?
The other is malingering. This is also the conscious and deliberate fabrication or exaggeration of illness. But the motivation is different from factitious disorder.
How so?
In malingering, the goal is a clear, tangible, external, secondary gain. It's outright deception and essentially fraud for a specific payoff.
Like what kind of payoff?
Things like obtaining insurance money or disability benefits, acquiring prescription drugs, especially opioids or stimulants, avoiding legal consequences like jail time or military service, or getting out of work obligations. Unlike factitious disorder, where the motivation is the sick role itself, malingering has a clear external reward.
So faking an injury to get insurance money.
Exactly. That's classic malingering. For nurses, it's important to avoid stereotyping these individuals. While it's deception, inquiring about the underlying motive or situation without judgment can sometimes be helpful. All behavior, even deceptive behavior, usually has a reason behind it.
Right, so given these very different presentations, genuine somatic symptoms versus consciously fabricated ones, what are the overarching nursing principles for approaching these very disorders?
The nursing approach requires a very thoughtful, consistent, and non-judgmental strategy. Assessment is absolutely key and can be quite complex. A major goal is trying to determine if the symptoms are under voluntary control, which is critical for differentiating somatic symptom disorders from factitious disorder or malingering, although this can be very difficult.
What else in assessment?
We must recognize that patients with true somatic symptom disorders genuinely may not see the connection between their physical symptoms and any underlying psychological stress. Dismissing their physical complaints is counterproductive. And given the high levels of distress, especially in SSD, we must always assess for suicide risk.
And in terms of intervention?
Establishing integrated care, often involving both medical and mental health providers, is crucial. Building a strong therapeutic relationship based on trust is foundational, showing you take their suffering seriously. Patient education about the disorder's manifestations is vital, along with psychosocial support, teaching coping skills, and perhaps assertiveness training.
Consistency seems important.
Very. Continuity of care with a primary provider is key to avoid fragmentation and unnecessary tests. Frequent, brief, regular visits can sometimes be more helpful than long, infrequent ones. Always conduct a thorough physical exam to rule out or manage any actual co-occurring medical conditions. And again, absolutely avoid disparaging comments that imply their symptoms aren't real or are all in their head. The goal is often realistic, focusing on improving function and reducing distress, even if some symptoms persist. #, the unseen world of sleep-wake disorders and their profound impact.
Okay, let's transition now to something absolutely fundamental to our overall well-being. Sleep. Why is it so incredibly important? It seems obvious, but what's really going on when we sleep?
It seems obvious, but the depth of its importance is often underestimated. Sleep is profoundly vital. It's truly as critical to our health as proper nutrition and regular exercise. It's a naturally occurring, altered state of consciousness that is absolutely essential for both our physical and emotional health.
So it's not just turning off.
Not at all. During sleep, our bodies and minds are incredibly active, engaging in crucial processes. It facilitates restoration and repair of tissues throughout the body. It plays a key role in memory consolidation, transferring information from short-term to long-term storage. It supports cognitive processing, essential for learning, problem-solving, and creativity.
And emotionally.
Hugely important for emotional regulation. It helps us process emotions, manage stress, and maintain a stable mood. And critically, it supports our immune system, helping us fight off infections. It's an active, essential restorative process.
And the impact of not getting enough sleep, chronic sleep deprivation,
Yeah.
it's pretty far-reaching, isn't it? It seems to cascade through every system.
It truly does. The effects are pervasive and significant. Chronically inadequate sleep leads to major cognitive impairment. Things like decreased concentration, poor memory, impaired judgment, reduced reaction time, poor decision-making.
Makes sense. You feel foggy.
Exactly. Emotionally, it causes emotional instability, increased irritability, mood swings, a reduced capacity to handle stress, higher risk of anxiety and depression. From a safety risk perspective, it greatly heightens the risk for accidents, particularly drowsy driving, which can be as dangerous as drunk driving.
Wow. What about physical health?
Big impacts there, too. It weakens the immune system, making you more susceptible to illness. It increases the risk of serious cardiovascular problems like high blood pressure, heart attack, and stroke. It contributes to metabolic disturbances, increasing the risk of type 2 diabetes and obesity due to hormonal changes affecting appetite and metabolism. It can even increase pain perception.
So it literally hurts more when you're tired.
It can, yeah. Ultimately, all this culminates in a significant reduction in overall quality of life, affecting work performance, relationships, and general well-being.
Okay, message received. Sleep is critical.
Yeah.
So what are some of the most common sleep disorders we should be aware of?
Right, let's delve into a few of the most prevalent sleep disorders that disrupt this vital process.
Save the way.
Okay, insomnia is by far the most common sleep disorder. It's characterized by persistent difficulty falling asleep, staying asleep, or experiencing non-restorative sleep, waking up feeling unrefreshed. This leads to significant daytime distress or impairment. It can be acute, short-term, often related to stress, or chronic, lasting months or longer.
Trouble sleeping. Got it. What else?
Then there's narcolepsy. This is a chronic neurological condition, not just being tired. It causes overwhelming daytime sleepiness and sudden, irresistible sleep attacks, where someone might fall asleep unexpectedly, even mid-activity.
Sleep attacks.
Yes. And often, narcolepsy comes with cataplexy, a sudden, brief loss of muscle tone, often triggered by strong emotions like laughter or surprise. They might just go limp for a moment. It's linked to a deficiency of a brain chemical called hypocretin.
Okay, narcolepsy with cataplexy. Next.
Breathing-related sleep disorders. These involve disruptions in breathing during sleep. The most common type by far is obstructive sleep apnea, OSA.
Snoring.
Loud snoring is a common symptom, yes. But in OSA, the airway actually repeatedly becomes blocked or collapses during sleep, leading to pauses in breathing, gasping, and very fragmented, poor quality sleep. Often the person isn't even aware of how many times they wake up briefly.
That sounds exhausting.
It is. Less common is central sleep apnea, CSA, where the brain actually fails to send the proper signals to the breathing muscles.
Okay, apnea. Any others?
Restless leg syndrome, RLS. This is a neurological disorder characterized by an irresistible urge to move the legs, usually accompanied by uncomfortable or creepy-crawly sensations. It's typically worse at rest or at night, and moving the legs provides temporary relief, makes it very hard to fall asleep.
Restless legs. One more.
Yes, hypersomnolence disorder. This involves excessive daytime sleepiness despite getting sufficient main sleep, like 7 hours or more. People with this disorder often take long, unrefreshing naps and struggle with sleep inertia, that groggy feeling upon waking. But unlike narcolepsy, they don't typically have cataplexy.
So excessively sleepy even after sleeping enough. Got it. Given these varied disorders, how do nurses typically assess and intervene for sleep issues?
Nurses play a vital role here. Assessment starts with gathering subjective data from the patient, getting a detailed history of their sleep patterns, sleep quality, any napping habits, daytime sleepiness levels, use of caffeine or alcohol, bedtime routines.
Asking lots of questions.
Exactly. Then we gather objective data, observing for signs of fatigue, irritability, difficulty concentrating. We might review their medical history for conditions associated with sleep problems. If a disorder like OSA or narcolepsy is suspected, a polysomnography or sleep study might be ordered. That's the gold standard diagnostic test, where they monitor brain waves, breathing, heart rate, etc. overnight.
Okay, assessment. What about interventions? What can people do?
Once sleep issues are identified, interventions heavily emphasize sleep hygiene. This is foundational, non-pharmacological stuff that everyone can benefit from.
Like what? Basic rules for good sleep.
Pretty much. Key sleep hygiene principles include establishing a consistent sleep-wake schedule, even on weekends. Go to bed and wake up around the same time. Creating an optimal sleep environment. Make sure the bedroom is dark, quiet, cool, and comfortable. Creating an optimal sleep environment. Avoiding stimulants like caffeine and nicotine, especially in the afternoon and evening. Also avoiding heavy meals or excessive fluids close to bedtime. Creating an optimal sleep environment. Engaging in regular exercise, but generally not within a few hours of bedtime, as it can be alerting for some. Creating an optimal sleep environment. Limiting daytime naps, especially long or late ones. Creating an optimal sleep environment. Avoiding screen time from phones, tablets, computers for at least an hour before bed, as the blue light can suppress melatonin production.
Those sound like good habits for everyone, really.
They are. Beyond basic hygiene, cognitive behavioral therapy for insomnia, CBTI, is a highly effective, evidence-based therapy. It teaches strategies to challenge negative thoughts about sleep, restructure maladaptive sleep habits, and use techniques like stimulus control and sleep restriction. Relaxation techniques, deep breathing, meditation, progressive muscle relaxation can also be very beneficial.
And medications.
Pharmacological interventions, sleeping pills may be used sometimes, particularly for short-term relief, but they often come with side effects and potential for dependence. They're usually considered after non-pharmacological approaches have been tried and always require careful monitoring. The overall goal is sustainable restorative sleep for better health.
Okay, let's tackle another major area now. Neurocognitive disorders. This includes things like dementia. A big question many people have is how to differentiate between just, normal aging forgetfulness and something more serious like dementia.
That's a crucial distinction, absolutely. And it causes a lot of anxiety for people as they get older. Let's break it down. In normal aging, individuals might experience occasional forgetfulness, maybe momentarily forgetting a name or where they put their keys or having trouble finding the right words sometimes, but they usually remember it later or can retrace their steps.
The tip of the tongue feeling.
Exactly. They might take a bit longer to make decisions or process information, but their overall function, their ability to manage daily life, remains intact. They typically maintain independence in activities like managing finances or driving, and they are usually aware of their occasional forgetfulness and might even jerk about it.
Okay, that sounds familiar. How does dementia differ?
Dementia involves a progressive and much more significant decline in cognitive function that interferes with daily life and independence. Individuals with dementia frequently forget recent events, conversations, or information and don't remember it later, even with reminders. They repeatedly have difficulty finding words, following conversations, or understanding concepts.
More pervasive difficulties.
Yes. Judgment becomes impaired, making poor financial decisions, for example. They might get lost in familiar places. Crucially, there's an increasing reliance on others for daily tasks like dressing, cooking, or managing medications. There are often significant personality changes, becoming more withdrawn, suspicious, or agitated. And quite commonly, a key difference is that individuals with dementia are often unaware of or deny their memory problems due to that anosognosia we discussed earlier.
That lack of insight again. Okay, that distinction is really helpful. Now, our sources, and Dr. Harp especially, truly emphasize that delirium is an acute medical emergency. Why is it so critical to recognize and address immediately? What makes it different from dementia?
Yes, delirium is absolutely a medical emergency requiring immediate attention. Dr. Harp specifically highlighted it as an acute, often reversible cognitive disturbance characterized by a sudden onset and disorganized thinking. It's critical because if the underlying cause isn't identified and treated promptly, it can lead to serious complications, including permanent neurological damage, prolonged hospitalization, functional decline, institutionalization, or even death.
So rapid onset is key.
Exactly. Unlike dementia, which typically develops gradually over months or years, delirium has an abrupt onset, often developing over hours or days, and its symptoms tend to fluctuate rapidly throughout the day. Someone might be lucid one moment and very confused or agitated the next.
What are the core features?
Key features include inattention, a profound difficulty focusing, sustaining, or shifting attention, and an altered level of consciousness, ranging from drowsiness to hypervigilance and agitation. Thinking is disorganized, speech might be incoherent, and perceptions can be altered, sometimes including hallucinations or illusions.
What causes delirium?
The causes are often multifactorial, but usually relate to an underlying medical condition, substance intoxication or withdrawal, or medication side effects. Common triggers include infections like UTIs or pneumonia, dehydration, electrolyte imbalances, low oxygen, hypoxia, severe pain, surgery, taking multiple medications, polypharmacy, and sleep deprivation. Identifying and treating that underlying cause is the absolute priority.
And nursing intervention.
Focus squarely on finding and treating the cause. Also, providing a safe, calm, well-lit, and orienting environment, frequent reminders of time, place, person. Supporting adequate fluid intake and nutrition is vital. Minimizing unnecessary medications. Promoting sleep. Delirium can often be reversed if treated quickly.
Okay, delirium, acute, fluctuating, medical emergency. Now, what about Alzheimer's disease, the most common type of dementia?
Right. Alzheimer's disease, AD, accounts for the majority of dementia cases. It's a progressive and currently irreversible neurodegenerative condition that gradually destroys memory and thinking skills. It typically unfolds in stages.
What are the stages generally?
They're often categorized broadly. Mild Alzheimer's, early stage. Individuals may experience memory lapses like forgetting familiar words or the location of everyday objects. Difficulty with planning, organizing, or complex tasks becomes noticeable. They might still function independently in many ways. Moderate Alzheimer's, middle stage. This is typically the longest stage. Confusion worsens, memory loss deepens, especially for recent events. Individuals may need help with daily tasks. Frustration, anger, or unusual behaviors like wandering or suspiciousness can emerge. Sleep disturbances are common. Severe Alzheimer's, late stage. In the final stage, individuals lose the ability to respond to their environment, carry on a conversation, and eventually control movement. They require full-time, around-the-clock care for all basic needs, including eating and personal hygiene. Communication becomes very limited.
A devastating progression. And one of the cardinal symptoms, I recall our sources mentioned something about the 4 A's for Alzheimer's.
Yes, the 4 A's are considered cardinal symptoms, key characteristics of the cognitive decline in Alzheimer's. Amnesia, memory impairment, particularly difficulty learning new information or recalling previously learned information. This is often the earliest and most prominent symptom. Aphasia, language disturbance. This can manifest as difficulty finding the right words, anomia, problems understanding spoken or written language, or eventually loss of ability to speak. Apraxia, impaired ability to carry out motor activities despite intact motor function. Difficulty performing purposeful movements like getting dressed, using utensils, or brushing teeth even though they have the physical ability. Agnosia, failure to recognize or identify objects despite intact sensory function. Not recognizing familiar faces, even family members, common objects, sounds, or smells.
Amnesia, aphasia, apraxia, agnosia.
Yeah.
The 4 A's. Got it. Now, something else often seen in dementia is confabulation. What exactly is that, and how does it differ from just, well, lying?
Confabulation is a fascinating memory disturbance. It's where a person fills in gaps in their memory with fabricated, distorted, or misinterpreted information. But, and this is the critical difference from lying, they do this without the conscious intent to deceive.
So they believe the false memories.
Yes, they genuinely believe their fabricated story or memory is real. It's like their brain is trying to make sense of missing information and unconsciously creates a narrative to fill the void. It's often seen in conditions that affect memory centers in the brain, like dementia, Korsakoff syndrome, related to chronic alcoholism, or certain brain injuries. Lying, in contrast, involves intentional deception.
Okay, unintentional fabrication to fill memory gaps. That makes sense. Now, caring for someone with Alzheimer's, it's incredibly challenging, isn't it? Our sources really underscore the impact on caregivers.
Immensely so. The physical, emotional, and financial toll on caregivers is enormous. The responsibilities are often long-term, demanding, and emotionally draining. Caregiver role strain is a very common and critical nursing diagnosis.
What can nurses do to support these caregivers?
Nurses play a vital role. Education is key, helping caregivers understand the disease progression, what to expect, how to manage challenging behaviors. Encouraging them to utilize respite care, getting temporary breaks, is crucial for preventing burnout. Connecting them with support groups where they can share experiences and feel less alone is invaluable. Teaching stress management techniques and referring them to community resources are all crucial interventions to support their own well-being.
Support for the supporter, very important. How do healthcare professionals quickly assess cognitive status in these situations? Is there a standard tool?
One of the most widely used and validated tools for a quick screening of cognitive status is the Mini Mental State Examination, or MMSE.
The MMSE, what does it measure?
It's a 30-point questionnaire that assesses various cognitive domains in about 10 minutes. It covers orientation to time, year, season, date, day, month, and place, state, county, town, hospital floor, 10 points. Registration, ability to immediately repeat 3 unrelated words, 3 points. Attention and calculation, spelling world backward or counting backward from 100 by 7 nulls, 5 points. Recall, ability to remember the 3 words from registration after a delay, 3 points. Language, Naming objects, repeating a phrase, following a three-stage command, reading and obeying a written command, writing a sentence, and copying a complex geometric design, 9 points.
Okay, quite comprehensive for a quick test. How are the scores interpreted?
Scores range from 0 to 30, generally, 25-30. Normal cognition or questionable significance, 20-24. Mild cognitive impairment, 10-19. Moderate cognitive impairment, less than 10. Severe cognitive impairment.
How do nurses use the MMSE?
It's used for baseline assessment, tracking changes over time, helping differentiate between conditions like delirium, where scores might fluctuate rapidly, and dementia, where decline is usually gradual, monitoring the effects of medications and informing care planning. It's quick and widely recognized, though it can be influenced by education level or language barriers, and might not be sensitive enough to detect very mild impairment.
Good tool to know. Beyond Alzheimer's, what are some other significant types of dementia we should be aware of briefly?
While Alzheimer's is the most common, it's vital to recognize others, as their presentation and progression can differ. Frontotemporal lobar degeneration, FTD. This often strikes earlier than AD. Key features are early changes in personality behavior, like impulsivity or apathy, or language, difficulty speaking or understanding, rather than memory loss being the initial primary symptom. Lewy body dementia, LBD. Core features include fluctuating cognition, big swings in attention and alertness, recurrent, vivid visual hallucinations, and Parkinson-like motor symptoms, rigidity, tremors. People with LBD are often very sensitive to antipsychotic medications. Parkinson's disease dementia, PDD. Here, the characteristic motor symptoms of Parkinson's, tremor, rigidity, slow movement, typically precede the onset of significant cognitive decline by at least a year. Dementia occurs later in the disease progression for some individuals with Parkinson's, TBI-related neurocognitive disorder. This follows a traumatic brain injury, either a single severe one or repeated milder ones. Cognitive deficits often involve impaired attention, memory, and executive function. Mood and behavior changes are also common. Vascular neurocognitive disorder. This results from problems with blood supply to the brain, typically due to multiple small strokes or other cerebrovascular disease. The cognitive decline often occurs in a stepwise pattern, with sudden drops in function after each vascular event, rather than the gradual decline typical of AD.
Okay, important to know, there are different types with different features. What are the general nursing care principles that apply across all these neurocognitive disorders?
Across the board, several principles are crucial for providing compassionate and effective care. 1. Communication. Use slow, clear, simple sentences. Maintain eye contact. Use nonverbal cues like touch appropriately. Validate feelings even if the content seems illogical. Avoid arguing or correcting constantly. Use reminiscence therapy. 2. Environment. Maintain consistency. Minimize changes in routine or surroundings. Reduce excessive stimulation, noise, clutter. Ensure safety, prevent falls, wandering, access to hazards. Use clocks, calendars, familiar objects for orientation. 3. Behavior management. Try to anticipate needs, hunger, thirst, toileting that might trigger agitation. Provide structured, meaningful activities. Use distraction or redirection rather than confrontation for challenging behaviors. 4. Patient and family education support. Provide ongoing education about the disease, care strategies, and available resources. Connect families with support groups. Address caregiver stress. Involve family and care planning. Promote dignity and personhood throughout the disease process.
Okay, let's explore another complex area, personality disorders. First off, how do we even define personality itself, and then what makes it cross the line into a disorder?
Good question. Personality is essentially our unique, enduring pattern of thinking, feeling, and behaving. It's how we consistently experience ourselves, perceive the world, and relate to others. It develops over time and is relatively stable, though it can evolve slowly.
So just who we are.
In a nutshell, yes. A personality disorder, PD, however, is very different. It involves persistent, rigid, and inflexible patterns of inner experience and outward behavior that significantly deviate from the expectations of the individual's culture.
Rigid and inflexible.
Exactly. These ingrained patterns cause significant distress to the person or, very often, impairment in their social, occupational, or other important areas of functioning. They have trouble adapting to different situations.
So they common.
They are quite common, actually, but often go untreated. Diagnosis usually occurs in adulthood, as personality patterns need time to solidify. A core feature across many PDs involves pervasive problems with self-identity, self-direction, empathy, and intimacy.
And do people with PDs realize they have a problem?
Often, a major challenge is that individuals with a personality disorder lack insight into how their own behaviors, thoughts, and feelings are problematic or impact others. They tend to blame external circumstances or other people for their difficulties. Psychotherapy, especially long-term therapy, is generally considered the treatment of choice, though it can be challenging.
Okay. Our sources describe personality disorders grouped into clusters. That seems like a helpful way to organize them. Can you break those down for us?
It is a useful framework, yes. They're grouped based on descriptive similarities. There are three clusters, A, B, and C.
Okay, cluster A.
Cluster A is known as the odd or eccentric cluster. Individuals in this group often appear suspicious, socially withdrawn, or awkward, and may hold unusual or peculiar beliefs.
Odd decentric. Which disorders are in cluster A?
This cluster includes paranoid personality disorder, characterized by pervasive distrust and suspiciousness of others, interpreting motives as malevolent; schizoid personality disorder, marked by a profound pattern of detachment from social relationships and a restricted range of emotional expression. They often prefer solitude. Schizotypal personality disorder involves significant social and interpersonal deficits, acute discomfort with close relationships, along with cognitive or perceptual distortions and eccentricities of behavior, like magical thinking or odd speech, sometimes seen as being on a spectrum related to schizophrenia.
Dr. Harp had a mnemonic for this one too, right?
Yes. For cluster A, think pass. Paranoid, constant new paranoid thoughts. Schizoid, prefer to be alone, extremely low extroversion. Schizotypal, sort of like low grade schizophrenia, difficulty relating.
Pass. Okay, cluster A, odd eccentric. What's cluster B?
Cluster B is the dramatic, emotional, or erratic cluster. Individuals in this group often display behaviors that are impulsive, overly dramatic, highly emotional, and sometimes erratic or attention-seeking. They may struggle with empathy and have tumultuous relationships.
Dramatic, emotional, erratic. Which ones are here?
Cluster B includes antisocial personality disorder, a pervasive pattern of disregard for and violation of the rights of others, often involving deceitfulness, impulsivity, aggression, and lack of remorse. Borderline personality disorder, BPD, characterized by instability in interpersonal relationships, self-image, and emotions, along with marked impulsivity. Fear of abandonment is central. Histrionic personality disorder involves excessive emotionality and attention-seeking behavior. Individuals often feel uncomfortable when they are not the center of attention. Narcissistic personality disorder, marked by a pattern of grandiosity in fantasy or behavior, need for admiration, and lack of empathy.
Okay, cluster B sounds intense. What about cluster C?
Cluster C is the anxious or fearful cluster. These disorders are characterized by prominent anxiety, fearfulness, and patterns of behavior driven by insecurity, a desire for control, or fear of negative evaluation or abandonment.
Anxious, fearful. And the specific disorders.
Cluster C includes avoidant personality disorder, characterized by social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation. They desperately want connection but fear rejection. Dependent personality disorder involves a pervasive and excessive need to be taken care of, leading to submissive and clinging behavior and fears of separation. Obsessive compulsive personality disorder, OCPD, marked by a preoccupation with orderliness, perfectionism, and mental and interpersonal control at the expense of flexibility, openness, and efficiency. Important note here.
What's the note?
OCPD is not the same as OCD, obsessive-compulsive disorder. This is a point Dr. Harp often emphasized.
How are they different?
OCD is an anxiety disorder characterized by intrusive thoughts, obsessions, and repetitive behaviors, compulsions, that the person usually recognizes as irrational but feels driven to perform. OCPD is a personality disorder where the preoccupation with perfectionism, order, and control is egosyntonic, meaning the person sees these traits as a normal and valued part of their identity, not as intrusive or unwanted like in OCD. They don't typically have the specific obsessions and compulsions of OCD.
Ah, okay. OCD is about the personality style. OCD is about the specific obsessions, compulsions. Big difference. Thanks. Let's maybe spotlight a few key examples from each cluster to get a clearer picture of the behaviors and nursing approaches.
Certainly. Let's look at some prominent examples and how nurses might interact.
Starting with cluster A.
Okay, from cluster A, odd-eccentric. Paranoid PD. Deeply distrustful, suspicious, holds grudges, sees threats everywhere. Nursing approach. Be very straightforward, professional, honest, and consistent. Use clear, simple language. Avoid being overly friendly. Gain trust slowly. Don't challenge their paranoid thoughts directly, but focus on reality. Schizoid PD. Emotionally detached, indifferent to praise or criticism, prefers solitary activities, lacks close friends. Nursing approach. Respect their need for privacy and isolation. Don't force socialization. Focus on practical matters. Be professional and unobtrusive. Schizotypal PD. Odd beliefs, magical thinking, unusual perceptual experiences, peculiar appearance or speech, social anxiety, nursing approach. Respect their individuality. Monitor for suicidal thoughts or brief psychotic episodes. Avoid ridicule or judgment of their beliefs' appearance. Focus on improving social skills and reality testing gently if needed.
Okay, cluster A approaches: professional distance, respect isolation, gentle reality testing. Now for cluster B, the dramatis erratic ones. These sound challenging.
They definitely can be. From cluster B, dramatic, erratic, emotional, histrionic PD. Needs to be center of attention, dramatic, shallow emotions, uses physical appearance to draw attention, often sexually provocative. Nursing approach. Maintain professional boundaries strictly, ignore flirtatious or seductive behavior, help them focus on their own feelings rather than external validation, set limits on attention-seeking behavior. Narcissistic PD. Grandiose sense of self-importance, entitled, requires excessive admiration, lacks empathy, exploits others, fragile self-esteem beneath the arrogance. Nursing approach. Remain neutral and non-confrontational, avoid power struggles, set firm limits on demanding or entitled behavior, role model empathy, focus on realistic goals.
Neutrality and boundaries seem key there. What about BPD and antisocial? These seem particularly complex.
They are and require very careful management. Borderline personality disorder, BPD. Intense fear of abandonment, unstable relationships, idealization versus devaluation splitting, identity disturbance, impulsivity, spending, sex, substance abuse, reckless driving, binge eating, recurrent self-harm or suicidal behavior, chronic feelings of emptiness, intense anger. Nursing approach. This requires a highly consistent, united staff approach to avoid splitting the team. Set clear, consistent boundaries and enforce them calmly. Respond to self-injury in a matter-of-fact way, addressing the wound, exploring the trigger feeling without giving excessive attention. Avoid manipulation traps. Focus on safety, coping skills like DBT, dialectical behavior therapy, and emotional regulation. Suicide risk is very high, 70% attempt rate, 10% mortality. Antisocial personality disorder, sociopathy, disregard for social norms and laws, deceitful, manipulative, impulsive, aggressive, lack of remorse, irresponsible, often charming superficially. Childhood precursors often conduct disorder. Nursing approach. Safety is paramount for self and others. Set firm, clear, consistent limits and consequences for rule breaking. Avoid power struggles and manipulation. Maintain a neutral, objective stance. Focus on accountability for behavior. Encourage empathy development, though this is very difficult.
Wow. Consistency, boundaries, safety, and avoiding manipulation seem critical for cluster B. Okay, finally, cluster C, the anxious, fearful ones.
Yes, cluster C, anxious, fearful. Avoidant PD. Social inhibition, feelings of inadequacy, hypersensitive to criticism or rejection, avoid social situations despite longing for connection. Nursing approach, build trust gradually and gently, provide reassurance, encourage them to take small social risks, promote assertiveness training, be patient and accepting. Dependent PD. Difficulty making decisions without advice, needs others to assume responsibility, fears being alone, urgently seeks new relationship when one ends, fears abandonment. Nursing approach. Encourage independence and self-reliance gradually. Help them identify their own strengths and abilities. Support them during times of stress, but avoid doing things for them. Teach assertiveness and decision-making skills. Obsessive-compulsive personality disorder, OCPD. Preoccupied with details, rules, lists, order. Perfectionism interferes with task completion, excessively devoted to work, rigid, stubborn, reluctant to delegate. Nursing approach. Avoid power struggles over the need for control. Allow them time for their routines and rituals if possible. Help them see how rigidity impacts their life. Focus on coping with unexpected changes. Encourage flexibility.
Okay, so cluster C involves building trust, encouraging independence, and managing perfectionism carefully. Given the complexities across all clusters, what are the overarching nursing strategies that really apply broadly?
Across the board, several strategies are foundational. 1. Establish trust and clear boundaries. This is paramount but often challenging. Use consistent, structured approaches. Maintain clear professional boundaries to avoid enmeshment or manipulation. Use neutral, non-judgmental language. 2. Promote safety. Continuously assess and monitor for risk of self-harm or aggression, especially crucial with BPD and antisocial PD. Set firm but non-punitive limits on unacceptable behaviors. 3. Support emotion regulation and coping. Teach and reinforce coping skills, stress management techniques. Help them identify triggers for impulsive or maladaptive behaviors. Role model calm, respectful communication. Validate feelings without necessarily validating the behavior. 4. Encourage responsibility and accountability. Avoid enabling manipulation, excessive dependency, or blaming others. Help individuals connect their behaviors with consequences. Promote self-awareness and reinforce positive changes and responsible actions. Collaboration with therapists providing specific modalities like DBT is often key.
Okay, let's transition now to a different kind of challenge.
Yep.
Crises. How do we define what constitutes a crisis, and are there different types we should understand?
A crisis is generally defined as an acute, time-limited event or situation that overwhelms an individual's usual coping mechanisms. It leads to a state of psychological disequilibrium, distress, and functional impairment. The person feels unable to manage.
Overwhelmed and unable to cope. Are there different kinds?
Yes, we often categorize them into 3 main types to understand their origins. 1. Maturational crisis. These occur as individuals move through normal developmental stages in life, but find their existing coping skills are ineffective for the new challenges. Think of adolescence, leaving home for college, getting married, the birth of a child, retirement. These are predictable life transitions that can still trigger a crisis. 2. Situational crisis. These arise from specific, often unanticipated external events that are stressful and disrupt a person's life. Examples include losing a job, the death of a loved one, especially if sudden, experiencing a serious illness or accident or divorce. 3. Adventitious crisis. These are sometimes called disasters. They are traumatic, unexpected, and often catastrophic external events that are not part of everyday life and usually impact large groups of people. They can be natural disasters like hurricanes, earthquakes, floods, epidemics, or human-made like acts of violence, terrorism, war, mass shootings, major accidents like plane crashes.
Okay, maturational, situational, adventitious. And in any crisis situation, if I'm understanding correctly from our sources, safety and anxiety reduction are the absolute immediate priorities for helpers.
That's precisely right. When someone is in crisis, the immediate goals of intervention are always: first, ensure their physical and psychological safety, and second, rapidly reduce their anxiety level to help them regain some sense of control and begin to mobilize coping resources. Interventions vary based on the crisis, but might include providing support, ensuring basic needs are met, active listening, and problem solving.
Is there a specific intervention for after major traumatic events?
Yes. One important tool used, particularly after adventitious crises, is critical incident stress debriefing, CISD. This is a structured group process, a form of psychological first aid or tertiary prevention, designed to help individuals process a traumatic event, reduce acute stress symptoms, and promote adaptive coping and healing. It might be used with first responders, hospital staff after a traumatic patient event, or community members after a disaster.
Okay, good to know. Now let's talk about something universal and deeply personal. Grief. How do we understand this complex process?
Grief is indeed a universal, multifaceted response to loss. It encompasses a wide range of reactions: emotional, sadness, anger, guilt; cognitive, disbelief, preoccupation with the loss; spiritual, questioning faith, finding meaning; behavioral, crying, social withdrawal, sleep appetite changes; and physical, fatigue, aches, pains.
Now, the Kubler-Ross stages.
Yes, Elizabeth Kubler-Ross's 5 stages of grief denial, anger, bargaining, depression, and acceptance, DABDA, provide a widely recognized framework.
Yeah.
However, it's crucial to remember, as Dr. Harp often pointed out, that individuals do not necessarily move through these stages in a neat, linear fashion.
Right, it's not a checklist.
Exactly. People may cycle back and forth between stages, experience several simultaneously, or skip stages entirely. It's more a description of common experiences within grief, not a rigid prescription for how grief should unfold.
Are there different types of grieving that we should recognize? It seems like grief wouldn't always look the same.
Absolutely. Grief manifests in various forms, and recognizing these can help tailor support. Normal, uncomplicated grieving. This encompasses the typical expected range of feelings and behaviors after a loss. As nurses or helpers, our role is primarily supportive. Active listening, encouraging expression of all feelings without judgment, providing a supportive presence, normalizing their experience. Persistent complex bereavement disorder, formerly complicated grief. This is diagnosed when grief is prolonged, intense, debilitating, and interferes significantly with functioning well beyond what's considered typical for the person's culture and context, usually lasting more than 6-12 months. Nursing care might involve protecting them from self-harm if hopelessness is severe, assisting with daily functioning and referral for specialized therapy. Disenfranchised grief. This type occurs when a person experiences a loss that isn't openly acknowledged, socially sanctioned, or publicly mourned. Examples include the death of an ex-spouse, a secret lover, a pet, a loss due to abortion, or grief over someone with severe dementia who is still physically alive. Because the grief isn't legitimized, individuals often lack social support and may feel their feelings are invalid, requiring individualized validation and support. Grief caused by public tragedy. This describes a loss felt broadly across a community or even a nation after events like mass shootings, terrorist attacks, or natural disasters. It can threaten a collective sense of security and shared worldviews. Nursing involves acknowledging the personal impact even within a large-scale event.
That's helpful, recognizing those different forms. How does grief differ from clinical depression? They can sometimes look similar on the surface, with sadness and loss of interest.
This is a critical distinction, often emphasized in clinical practice. Grief is a natural, albeit painful, process. It's a direct response to a specific loss. While intense sadness is present, it often comes in waves or pangs, interspersed with periods of positive memories or even moments of humor. Over time, the intensity generally lessens, even if sadness resurfaces occasionally. Crucially, in uncomplicated grief, self-esteem is typically preserved. The person feels sadness about the loss, but not usually pervasive worthlessness about themselves.
And depression.
Major depression, on the other hand, is a clinical mood disorder. It may or may not have a clear external trigger. It involves a more pervasive sadness, depressed mood, or inability to feel pleasure, anhedonia, that is persistent, not just in waves. It's often accompanied by significant feelings of worthlessness, hopelessness, excessive guilt, and thoughts of death or suicide that are focused on oneself. Depression significantly impairs daily functioning across multiple areas: work, social, self-care, and often persists or worsens without specific treatment. While grief can sometimes trigger depression, they are distinct states.
Pervasive low mood and worthlessness in depression versus waves of sadness related to loss and grief. Got it. And what about the physical changes at the very end of life? What are the signs people might observe as someone is actively dying?
In the active dying phase, typically the last days to hours of life, specific physiological changes often occur as the body systems begin to shut down. Common signs include a decreased level of consciousness, progressing from drowsiness to lethargy to unresponsiveness or coma. Sometimes terminal restlessness or agitation occurs. Cardiovascular changes. Mottled, cool extremities, especially hands and feet, as circulation decreases. A weak, thready pulse, dropping blood pressure. Respiratory changes. Irregular breathing patterns, like periods of rapid breaths followed by pauses, Cheyne-Stokes respirations. Increased respiratory secretions that the person can't clear, leading to noisy breathing, often called the death rattle. Respiratory changes. Decreased appetite and intake of fluids, and consequently decreased urinary output. General appearance. Skin may look pale or waxen.
And the senses.
Sensory perception diminishes, but crucially, our sources emphasize that hearing is often believed to be the very last sense to go.
So keep talking to them.
Absolutely. Even if the person appears unresponsive, it's vital to assume they can still hear you. Continue speaking calmly, reassuringly, sharing memories, saying goodbyes. It can be comforting for both the dying person and the family.
That's incredibly important to remember. How do we communicate effectively and compassionately, then, with those who are grieving or dying? I know Dr. Harp had a powerful reminder here.
This is such a vital skill, grounded in empathy, when talking to someone who is grieving. The most powerful thing is often simply being present. Sit with them. Listen more than you talk. Allow silence. Avoid cliches like, they're in a better place, be strong, or I know how you feel. These often feel dismissive or minimizing. Instead, use open-ended prompts. Tell me about them, or what's this been like for you? Acknowledge the pain. This must be incredibly difficult. Instead, use open-ended prompts. Offer practical help, like bringing food or running errands, rather than just saying, let me know if you need anything. Instead, use open-ended prompts. Most importantly, allow them to express all their feelings, sadness, anger, guilt, relief, without judgment. Your role isn't to fix it, but to witness and validate their pain.
In communicating with someone who is dying.
Speak calmly and clearly. Let them guide the conversation if they are able. Ask open-ended questions about their feelings, fears, or wishes. Don't force positivity. Validate their feelings, whatever they are. Reassure them of your presence, that they are not alone and that their comfort is the priority. And remember that hearing may be the last sense.
And Dr. Harp's key reminder.
Yes, Dr. Harp's nursing tip here is pure gold. Listening without fixing is one of the most powerful things you can do. It beautifully encapsulates the essence of compassionate presence for someone who is grieving or dying. It underscores that often the greatest gift we can offer is not advice or solutions, but simply our full, non-judgmental attention and empathy.
Listening without fixing. Powerful. Let's focus now specifically on older adults. How do cultural views influence aging, and what exactly is ageism?
Cultural views on aging vary dramatically across the globe, and even within societies. Some cultures deeply revere older adults, valuing their wisdom, experience, and role as keepers of tradition. They are respected and hold positions of authority. In contrast, other cultures, particularly Western society sometimes, may view aging more negatively, associating it with decline, dependency, loss of productivity, or being out of touch. This cultural lens profoundly influences how older adults are treated, the resources allocated to them, and how they perceive themselves in their own aging process.
In ageism.
Ageism is essentially prejudice or discrimination based solely on a person's age, typically directed towards older adults. It manifests as negative stereotypes. For example, all old people are forgetful, rigid, frail, or technologically inept. Discriminatory practices in employment, healthcare, and societal attitudes that devalue older individuals.
What are the consequences?
It can lead to social isolation, reduced access to healthcare, symptoms dismissed as just old age, limited opportunities, internalized negative self-perceptions, and overall poor health outcomes. As nurses and healthcare providers, our role is crucial. We must actively challenge ageist stereotypes in ourselves and others, promote the dignity and autonomy of older adults, and advocate for policies and practices that support active, healthy aging.
So, what are the key areas to assess when working with older adults, recognizing their unique needs?
Assessment in older adults needs to be truly holistic, considering the complex interplay of physical, cognitive, psychological, social, and functional factors. A very helpful screening tool often used to quickly identify common geriatric syndromes is the SPICES tool.
SPICES, what does that stand for?
It stands for sleep disorders, problems with eating or feeding, incontinence, confusion, evidence of falls, skin breakdown.
Okay, SPICES is a quick screen. What about a more comprehensive assessment?
A comprehensive geriatric assessment dives deeper. It covers their overall physical health, chronic conditions, medications, sensory function, cognitive function, using tools like the MMSE to screen for dementia or delirium, psychosocial health, mood, depression, anxiety, social support, screening for elder abuse, and crucially, their functional status.
Functional status?
Yes, assessing their ability to perform basic activities of daily living, ADLs, like bathing, dressing, toileting, transferring, continence, and feeding. And also instrumental activities of daily living, IADLs, which are more complex tasks needed for independent living, like managing finances, cooking, shopping, managing medications, using transportation, and using the telephone. Assessing functional status gives a real picture of their level of independence and support needs. Environmental safety is also key.
Got it. What about mental illness specifically in this population? Does it present differently?
Mental illness in older adults is common but often complicated by coexisting physical health issues, comorbidities, and sometimes symptoms can be mistaken for normal aging or physical illness. Late-life depression is particularly prevalent, but frequently under-recognized and undertreated. Symptoms might be more somatic, physical complaints, or present as apathy rather than overt sadness.
A suicide risk.
Tragically, suicide risk is highest among older adults compared to other age groups, with white males over the age of 85 being at the very highest risk. This is a critical point. Generalized anxiety disorder, GAD, is also common, often linked to worries about health, finances, or fear of falling. And while sometimes overlooked, alcohol is the most frequently abused substance by older adults, sometimes starting later in life after retirement or loss.
Highest suicide risk in older white males. That's vital to know. Finally, on this topic, Dr. Harp had a very specific, important point about therapeutic communication with older adults. What was that key insight?
Yes, this is a really practical and important point for effective communication, and Dr. Harp emphasized its significance. When an older adult expresses a negative feeling or a seemingly stereotypical statement about aging, for example, saying something like, "Every day is a struggle when you get old, no one cares about old people anyway," the best therapeutic nursing response focuses squarely on validating the underlying feeling and encouraging them to express more.
How would that sound?
An example of a good therapeutic response would be something like, "It sounds like you're having a really difficult time right now. Tell me more about what's making it a struggle for you."
So, acknowledging the feeling and opening the door.
Exactly. It acknowledges their emotional state, difficult time, shows empathy, and invites them to elaborate. Tell me more. What we absolutely must avoid are responses that are patronizing. Oh, don't say that, you have lots to live for. Immediately trying to fix it or focus only on the positive. Let's think about the good things. Denying their feelings, it's not that bad. Or making self-centered responses. Well, my grandmother felt that way too. The goal is to facilitate their expression, respect their experience, and build trust by showing you are truly listening to their struggle. #, serious mental illness and systemic challenges.
Okay, to wrap up our deep dive, let's look at the broader landscape of serious mental illness, or SMI, and then tackle a really significant systemic challenge facing our society today: transinstitutionalization. First, what exactly is SMI?
Serious mental illness, SMI, is a term used to refer to a group of psychiatric conditions, often understood as being primarily biological in origin, that result in serious functional impairment, which substantially interferes with or limits one or more major life activities.
So, conditions that significantly impact daily life. Like what?
It typically includes conditions like major depressive disorder, bipolar disorder, schizophrenia, schizoaffective disorder, and sometimes severe anxiety disorders or personality disorders, particularly if they cause significant impairment. The key is the level of functional disability if the condition is untreated. Statistics indicate that approximately 4.6% of U.S. adults live with SMI, which is a substantial number.
What are the core nursing approaches when working with patients living with SMI, often over the long term?
Nursing care for individuals with SMI is comprehensive, recovery-oriented, and requires a holistic perspective. Assessment involves evaluating risks of harm, both intentional harm to self or others, and unintentional harm that can result from the illness, like neglecting critical medical needs, poor nutrition, or unsafe housing.
What about monitoring?
We vigilantly monitor for symptoms of depression, anxiety, hopelessness, which can fluctuate. We also identify early warning signs or triggers for impending relapse, working with the patient to develop a relapse prevention plan.
And interventions.
Intervention strategies strongly emphasize involving the patient directly in their goal setting and treatment planning, fostering autonomy and shared decision-making. The focus extends beyond just symptom reduction. It's about enhancing their overall quality of life, finding meaning, purpose, connection, managing daily tasks. Sustaining long-term therapeutic relationships is paramount. Trust and consistency are vital.
What else?
We continue to encourage reality testing as needed, teach coping skills, and importantly, help patients learn how to respond effectively to the social stigma they often face. Promoting social skills and connecting them with peer support groups are also key. Crucially, nursing care involves addressing the whole person and their practical needs, helping navigate things like public transportation, finding stable housing, managing finances, accessing vocational support, and finding joy and engagement in life. It's truly holistic.
That holistic quality of life focus seems essential. Now, let's tackle this profound systemic issue you mentioned, transinstitutionalization. It sounds like a major challenge, and Dr. Harp underscored its importance. What is it?
It is a critical concept, absolutely, for understanding the current landscape of mental health care in the U.S. and many other places. Transinstitutionalization describes the unintended and often tragic phenomenon where individuals with serious mental illness who were previously treated in large state psychiatric hospitals have been shifted not primarily into robust community care, but into other institutional settings.
Shifted from one institution to another. Like where?
Primarily into jails and prisons, nursing homes, homeless shelters, and even spending prolonged periods in hospital emergency departments. This largely occurred following the movement of deinstitutionalization starting in the mid-20th century. The goal of deinstitutionalization was positive: to close down large, often inhumane state hospitals and integrate patients into community-based mental health centers.
But the community support didn't fully materialize.
Exactly. That's the crux of the problem. Adequate funding and development of comprehensive community mental health services, supportive housing, and vocational programs often lagged far behind the hospital closures. So many individuals with SMI were discharged without sufficient support structures in place.
So, in essence, as the state hospitals closed, our jails and prisons became the new default institutions for many people with SMI.
Precisely. It's a harsh and widely acknowledged reality. Jails and prisons like Rikers Island in New York or Cook County Jail in Chicago are now effectively the largest mental health providers in the U.S.
That's shocking.
It is. And these correctional facilities are generally ill-equipped to provide adequate psychiatric treatment. Incarceration itself often worsens symptoms, isolates individuals further, and hinders any hope of recovery. It's a cycle.
What about other settings?
We also see emergency departments severely overloaded. Psychiatric patients frequently board in ERs, sometimes for days or even weeks, waiting for an available inpatient psychiatric bed simply because there aren't enough beds or appropriate community placements. And a significant number of individuals with untreated or poorly managed SMI end up homeless, cycling between shelters, the streets, and brief hospitalizations, making consistent treatment nearly impossible. Older adults with SMI also often end up inappropriately placed in nursing homes that lack specialized psychiatric expertise.
What are the root causes driving this ongoing transinstitutionalization?
The root causes are multifaceted and deeply systemic: chronically underfunded community mental health care, simply not enough resources, staff, or programs to meet the need, lack of affordable and supportive housing, a major barrier to stability and recovery, persistent social stigma surrounding mental illness, leading to discrimination, lack of public political will for funding, and NIMBYism, not in my backyard, opposing local services, fragmented care systems, poor coordination between mental health, physical health, substance abuse treatment, housing, and criminal justice systems, criminalization of mental illness, where behaviors related to untreated symptoms like disorderly conduct or trespassing lead to arrest rather than treatment.
So what are the implications of this for nursing? Specifically, how can nurses make a difference in this challenging system?
The implications are profound, and nurses are often on the front lines of dealing with the consequences. We must be fierce advocates for our patients, advocating for appropriate treatment, housing, and community supports, challenging inappropriate discharges or placements. Promote trauma-informed care in all settings, recognizing the high rates of trauma among individuals with SMI, especially those involved with the justice system or experiencing homelessness. Collaborate actively with social workers, case managers, housing specialists, and legal aid to connect patients to essential resources. Support reentry planning for individuals leaving correctional facilities or hospitals, aiming to connect them immediately with outpatient care and housing to prevent recidivism and homelessness. Provide ongoing education to patients and families about navigating the complex system, understanding their rights, and accessing available resources. Nurses have a powerful voice in advocating for systemic change as well. #outro.
Wow. We have truly covered a tremendous amount of ground in this deep dive. I mean, from the intricate world of schizophrenia, its symptoms, phases, the critical medication side effects Dr. Hart flagged, then diving into the subtle, often confusing manifestations of somatic disorders.
Right, and the absolute fundamental impact of sleep and those challenging neurocognitive conditions like Alzheimer's and that emergency situation, delirium.
Exactly. And then unpacking the nuanced patterns of personality disorders, the universal human experiences of crisis and grief, the unique needs and strengths of older adults, and finally tackling that critical systemic challenge of transinstitutionalization. What a journey through such vital material.
It really highlights the immense scope of mental health, doesn't it? And the critical importance of understanding these foundational elements, especially those practical insights and nuanced points, like the ones Dr. Harp emphasized, that are needed for truly grasping this material and providing compassionate care. Our aim really was to give you a clearer, more connected understanding, hopefully helping you navigate this vital field with, well, greater confidence.
Indeed. I feel like I have a much better handle on these core concepts now. So, as you, our listeners, reflect on everything we've unpacked today, here's maybe a provocative thought for you to carry forward. Given the widespread impact of mental health conditions and those significant systemic challenges we discussed, like transinstitutionalization, what single small change, maybe in your own community or even just in your personal interactions, do you think could make the biggest difference in fostering empathy and improving care for those living with serious mental illness?
That's a great question to ponder. Consider that. The power of informed empathy, especially in a world just grappling with information overload and often, sadly, with stigma, is truly transformative. Even small acts of understanding can ripple outwards.
Absolutely. We hope this deep dive has given you plenty to think about, a clearer perspective, and maybe a valuable shortcut to being well informed on these crucial topics. Until next time, keep digging deeper.